Welcome back, everybody, to Medical Education in the New Millennium. My name is Nikita Joshi, and on behalf of the other course directors, Larry Chu and Kyle Harrison, we are very excited to have you here today. Today, we will be talking about patient safety, cognitive bias, and the medical training process. We are very excited to have here today Dr. Lauren Riskin and Dr. Marjorie Stiegler to talk about this topic. But first, for our Ignite speaker. Meredith is a QA technologist and patient safety data coordinator for the Department of Pathology at Johns Hopkins. At Hopkins, in addition to that role, she owns M Squared, a healthcare consulting agency, and also operates MoCA, the Empowered MoCA Patient Blog, which is an online healthcare resource for the African American community. First, we'll hear a few words from our sponsors, and then we'll hear from the Ignite Talk.
Welcome to Medical Education in the New Millennium, a new course from the Stanford University School of Medicine. This interdisciplinary course is produced by Stanford Med X and features talks from thought leaders and innovators from medical education, instructional design, cognitive science, online learning, and emerging technology. Over the course of 11 weeks, we'll consider how to build educational experiences that address the unique learning preferences of today's millennial medical students and residents, address gaps in the current medical education system, and explore what might be accomplished when all healthcare stakeholders are included in the conversation. If you are joining us for the first time, a quick reminder that there's a simultaneous conversation happening on Twitter right now using the hashtag MedX. Christopher Snyder, otherwise known as I Am Spartacus, is the in-class moderator for today's program and will be taking questions from social media. So please, make sure to start up your Twitter client to join in the online conversation and interact with today's speakers. Please also make sure to like our Facebook page at www.facebook.com/Stanford Med X. Please note, you are watching a live online program, and there is a delay between real-time events and the live stream you are watching. Tweets from our in-class guests will appear before you see the real-time events they are tweeting about unfold on the video live stream.
Patient safety is my job. I have a personal mission to contribute to the culture of safety by helping patients, advocates, consumers, learn how to be key players in their healthcare when they're consuming healthcare services. I took the plunge to I became a patient advocate by default, and I consider myself to be a patient or a safety evangelist because I took the plunge to start a blog to help patients and their families learn how to navigate the healthcare system and raise awareness about patient safety. I got started by targeting the African American community because there's such a disparity in clinical outcomes for us for several chronic conditions. Since that time, I've started a podcast and I've written an ebook, it's floating around out there, to help healthcare providers make some sense of the seemingly peculiar policies that the lab has for specimen rejection. And this is my mom. This is Virginia Hurston. She is the reason why I got started even being a patient advocate. She had chronic conditions she was a diabetic for several years, and I navigated the healthcare system with her. And what I learned is that when you gamble with patient safety, you bet their life. And in order to frame the context of the conversation, it's important to quantify the errors. And how many are familiar with the Institute of Medicine 1999 study, the errors to err is human? Most of us have heard of that by now. So they said that between 44,000 and 98,000 deaths occur each year as a result of preventable errors. And that was some 15 years ago. But to my surprise, in 2013, the Journal for Patient Safety released a new study, and it says that up to 440,000 preventable errors occur each year. That's an alarming number. And I have some stories of medical errors of my own, and one in particular is when my mom was in the intensive care. I went to see her one particular evening, and she was laying in bed. She wasn't really coherent, and I just, being my nosy usual self, I looked at the IV pole, and I noticed that an antibiotic that was hanging for her did not have her name on it. It had someone else's name on it and a different room number. So I went out to the nurse's station, And I said, hey, listen, there's this bag hanging, it's running, and it has someone else's name on it. It's for the person next door. She's like, oh, really? So she comes in the room. She's like, well, is she allergic to this particular drug? I said, no. She said, well, it'll be okay. I was so alarmed. That mortified me because the 5 rights of medication administration just kind of out of the window. So I think it is important for medical students, in order for them to be effectively prepared, you need to keep patient safety top of mind at all times throughout your career. And one of the main ways to do that is to use 2 patient identifiers. And it can be 2 of 3 things: the name, medical record, or date of birth. Try to use at least 2 of those each time you access the electronic medical record. When you go to act on a critical action value, if someone calls you, make sure that you write down the patient's name and their medical record number so that you're clear on who you're creating orders for to respond to that value. And when you're collecting and labeling specimens, it's really important that if you have access to barcode verification to scan their wristband, that you use that and not skip over that step as a workaround. And if you happen to make a mistake, admit the mistake. Start contributing and embracing the culture of safety. I know it's really difficult. No one wants to get in trouble and own up to their mistakes. But the idea is that it should not be punitive, because there's probably something wrong with the system. It's a system error that needs to be corrected. And if you bring that up, if you raise that awareness to the proper authority, it contributes to a better clinical outcome for the patient. And I don't really want to go down the rabbit hole today about workarounds, but just be mindful of workarounds. And when you notice a workaround for yourself or notice colleagues doing that, contact the Human Factors Engineering Office for an evaluation to get that corrected, because it's a system issue. And that's all I'll say about workarounds. But what you can do as medical students and as future medical doctors and healthcare professionals is be a champion for patient safety. You can do that on your own service or at the institutional level. And you should know the policies and procedures for your institution and understand why they exist. A lot of times people frown at policies because it takes away from them being efficient. But when you understand the why, it helps you understand why it's important for that patient's safety. And also what you can do is mobilize your patients. I'm a big fan of patient engagement, getting them involved in their own care. So you'll want to mobilize your patients and welcome them as a valued member of the healthcare team. And you can empower them by giving them recommended reading or pointing them to the appropriate community resources. They can be online, it could be a local support group, and then engage them. Ask them to bring questions to the visit, like write them down in advance. Or if it's a patient in the hospital, between rounds, from one day to the next, if they have questions, encourage them to jot them down or have a family member jot them down. And one resource that I like to recommend is doctella.com, particularly for patients that are having some sort of procedure. It's basically a bunch of questions that create a prompt that will help the patient dialogue with the doctor to ask about what to expect for their surgery, about how long they can expect to recover, how they'll be managing pain, and things like that. And also have the patient or their advocate give a recap of the visit in their own words. Make sure that they understand what prescriptions they should be taking, how often. Make sure they understand the directions and the treatment plan when they leave the office for that day. And then you want to activate your patients. You can assign them tasks. They can be the eyes and ears of safety in the hospital. They can watch out for hand washing, make sure they're observing everyone washing their hands when they come into the room. They can help with patient identification, make sure that before someone administers medication that they're checking their wristband. If the patient isn't coherent enough to do it themselves, if their advocate is there, that's something that they can participate in. It's a good thing to get the patient and their family involved. And if you're interested, on my website, I have 10 tips for families and friends of hospital patients to help them stay safe. So I can give you the link to that after class if you're interested in it. And finally, find balance. We know that the #1 goal when you go to work each day is to take care of your patient. And time is precious and it's a limited resource. But balance safety and efficiency, because we know that everyone needs to be efficient because there are so many tasks on your plate each day that you're trying to juggle. But add into that equation safety and balance safety with efficiency. And finally, I'll leave you with this. Patient safety isn't expensive. It doesn't cost you a lot, but it's priceless for the patient. And if you would like to connect with me, this is where you can find me online and on Twitter. And these are the links to my blog and my podcast. So now I would like to introduce our speakers for this evening. We have Dr. Marjorie Stiegler, and she is the Director of Consortium of Anesthesiology, Patient Safety, and Experiential Learning at the University of North Carolina, Chapel Hill, and she is also an Associate Professor of Anesthesiology. She received her medical degree from Emory University and her residency training at the Massachusetts General Hospital before joining UNC. She was a faculty member at UCLA, where she completed a fellowship in medical education. She sits on 4 national patient safety and quality committees and is an examiner for the American Board of Anesthesiology. She has received federal grant funding from AHRQ to study cognitive errors. And we also have Dr. Lauren Riskin. She is a board-certified anesthesiologist who has worked in policy, research, and technology in healthcare. She served on the Obama campaign for Healthcare Advisory Committee in 2008. She holds a degree in ethics from Wellesley College, a degree in medicine from Duke University, and completed anesthesia specialty training at Stanford University. We'll hear from them after this message from Med X.
In 2015, Medicine X will be launching a new program called Medicine X Ed. This special conference, right before Medicine X 2015, will focus on medical education and what might be accomplished when all healthcare stakeholders can engage in a conversation about changing the culture of medicine through educational innovation. Of course, we'll discuss the role technology can play in medical education, but we'll also look at gaps in our current educational system, such as participatory medicine, shared decision-making, patient engagement, cost transparency, patient safety and reducing harm, and cross-cultural competencies. What other gaps might we address at Medicine X Ed? Let us know what you think by tweeting our hashtag MedX. And make sure to sign up online to learn more about Medicine X Ed and how you can get involved.
So we're going to talk now about memory and cognition in medical decision making. I'm going to talk first about the traditional paradigm of medical education and how we think that we turn experiences into expertise. Let's take a little look at my funnel. You can see that we expect in medical training to take personal experience, such as patients that we take care of on the wards, or possibly simulated patients or standardized patients. And then we take vicarious experience. Vicarious experience includes patients that we hear about in case-based learning or problem-based learning conference. It might include patients we hear about in morbidity and mortality conference. It also includes patients that we talk about with our colleagues over a cup of coffee, and occasionally patients that we hear about on the news. And then theoretical experience. In the old-fashioned world, this is sort of your book learning. And I know in the modern day, there's probably a lot more multimedia and fewer books. But theoretical experience is the acquisition of those building blocks of cases that you have not seen, but are intended to prepare you to recognize cases when they come up. So reading, podcasts, videos, lectures like you're doing here. And the idea being that if we spend enough time taking care of patients and enough time going to conference and enough time reading our books, that we're going to pop out of the other end of the medical education funnel with medical expertise. I'm going to throw a few monkey wrenches at this in just a few minutes because it's not so much what experiences we have, but how we store and retrieve them. So when we think about how we access our experience, it's really important to understand that this is really a function of memory. So if I hear about a patient, or I take care of a patient, or I read about a patient, I have to store it. And experiences are stored in the brain as gists. They are not stored as verbatim, word for word, ability to access that story. It's a gist. And the brain really likes to have something that's simple and coherent. So remember, simple, short, coherent, that's what the brain likes. If you don't have the details in your brain, well, we're going to speak about this a little more later, if you don't have the details, your brain is likely to make them up for you because it likes a complete picture. As we get experience, we make gist collections. I've seen this just before, I've seen it again the next time, and eventually I have what's called a stereotyped illness script. And if you guys read the pre-reading on my blog, you'll have already read a little bit about what an illness script is. But it is essentially a pattern matching that an expert should be able to recognize immediately. So when you come out the other end of your funnel and you have all of your experience and you find a pattern matched Illness script, you say to yourself, really without a whole lot of thinking, aha, I know what that is. I retrieve it from my memory. It matches the illness script, and you make your diagnosis. You guys have learned a little bit earlier this year about type 1 and type 2 thinking, but let's review it quickly. There's intuitive and analytical thinking processes, and our scripts are in the category of the type 1 process, the fast thinking. Probably everybody in this room, without thinking about it whatsoever, knows that this is a cardinal on the right. This is a cardinal, or at least on your left. That's a cardinal, and you didn't even need to think about it. It just came readily to mind. You didn't need to do an assessment of the bird's features, the beak, geographically where the bird lives, what does the bird like to eat. We didn't need to think about any of those things because immediately you recognized it and knew what it was. That's type 1 fast thinking. The other bird, you don't probably know what it is, unless you're a bird scientist, and so you might have to evaluate some of those features. And once you've given careful consideration to those features, you're going to have to consult some decision support. So whether that be online or a book or an expert, you're going to have to go through this in a deliberate way that requires significant mental effort. Let's think about what that looks like in a schema. If you look at this image, you can see that the first question is the pattern recognized? And for the cardinal, the answer is yep, sure is, and we go all the way over to decision. You see we're on type 1 intuitive thinking, and that arrow goes all the way to decision without doing anything else. This happens almost in an instant, and I like to call it non-thinking, because you're probably not even aware of doing any mental calculation. If you don't recognize the pattern, then we go into type 2 analytical thinking, where we take all of the characteristics and we go to a calibration process, where we consult our experts or we get online, and then we make a decision. And by the way, in medicine, everything starts off type 2. You're a new medical student. You don't know any patterns. You don't know any patterns at all. But over time, you can see, I'm not sure if I can make this pointer work, but over time you can see that type 2 analytical processes that are repeated become recognizable patterns. So if you're following me up here, become recognizable patterns. And that is the process of learning. And eventually, as you become more and more expert, things that used to require mental effort now just seem obvious. Here's the problem. The number one cause of medical error in a diagnostic mistake happens right here. Pattern recognized. Up to 80% of diagnostic errors and patient harm are going wrong right there. Pattern recognized. We say yes, but the answer is actually no. And the other problem that compounds all of this is pattern recognized. We say yes, and nothing happens. We land on decision. There are no safety nets. There are no checks. We're going to talk about that. In order to know if we recognize a pattern, we have to consult our memories. And William Maxwell, who was a very famous editor at The New Yorker, has said, what we refer to confidently as memory is really just a form of storytelling that goes on in the mind and changes with the telling. What does he mean by that? Well, we know our experiences are stored as memory, and he says the memory changes with the telling. Let's think about that a little bit. The data changes with the telling. Probably everybody can relate to the idea of loss of data. You went to the store for 6 things, you came home with 4 things. What were the other 2 things? You can't remember. Or someone's phone number you forgot. That's easy. You're sitting for a test and you're scratching your head saying, I know I read that once, I just can't remember. So we lose data all the time. That is easy to understand. The next point of recall intrusion is a little bit more elusive to most folks. This is the idea that data that was not actually part of the original event is recalled. How does that happen? If you think about the example of an eyewitness to a crime, we know very often that those folks have a crystal clear image in their mind of what they believe that they saw. They probably have some of those details wrong, as we often find out later. But the brain puts context-coherent details in. So if you can't remember the color of the person's shirt, the brain will supply it. It was blue. Otherwise, they have on no shirt. The brain supplies the details. But when you see the mugshot later and find that the shirt was instead brown, when you think back to what you saw, you will remember brown. This will be incorporated into the memory. And you won't be able to tell the difference over time between what you actually remembered and what is a recall intrusion. These occur below the surface of consciousness. So real data and recall intrusions are indistinguishable. So data changes with the telling. The very act of trying to recall something is, again, not verbatim, not words on a page, but it is a reconstruction. And if it's a reconstruction, and the act of doing the reconstruction itself alters the memory, and then the new memory replaces the old memory via a process called reconsolidation. What happens then to our memories? This little photo reminds me of that telephone game that little elementary school kids play, where you tell the first person a phrase and they whisper it, and then they whisper it to the next person. And by the time you get to the end of the line, what comes out of that kid's mouth has really nothing to do with the original phrase. They're totally different. And so too it can be with our memories. This is really important because when you think back about patients that you have treated or patients that you heard about or things that you have read, you have got to take what you remember with a grain of salt. It may not be completely an accurate representation of the truth. Then we have another problem. What is memorable? We all know intuitively that not everything is equally memorable. I remember my wedding day. I remember where I was on 9/11. I cannot remember what I wore to work last Tuesday. It wasn't really all that long ago. There are a lot of things that make things memorable and other things less memorable. What are those? Well, frequent exposure is one. You see something often, the common cold. You see it, you get to know it. Frequent exposure makes things memorable. Vivid stories make things very memorable. I just read on the plane here the book by Chip and Dan Heath called Made to Stick. And they open that with the urban legend that almost everyone has heard. The guy goes out for a drink, meets a strange woman, wakes up in a hotel room next in a bathtub of ice, and his kidneys have been stolen. Everyone knows that urban legend. Even if you didn't know it before, you know it now. And when you leave this room, you'd be able to retell it. But you're not going to be able to retell all the details of my lecture, and you're not going to be able to retell all the details of the other lectures here tonight, because some things are vivid stories that are really, really memorable. Things that are emotionally charged. Everybody remembers their first death. Physicians will remember the patient that died in front of them the first time, and probably many of the subsequent patients. If a physician makes an error that causes grave harm to the patient, that becomes seared in the forefront of your mind. You'll never forget it. And it changes your practice in a way that may not really be evidence-based. Novelty, it's very interesting, right? Things that are neat are easy to remember. In medicine, we call them fascinomas, right? Or zebras. And then recent exposure. So something that might be very uncommon but has happened recently will come more readily to mind. So while we're talking about what makes things memorable, let's revisit the first slide. We are supposed to get a bunch of experiences, personal experience, vicarious experience, and theoretical experience, and it's supposed to come out and provide us with expertise that's supposed to come readily to mind. But what really comes readily to mind are the versions of these things that are common, recent, vivid, emotionally charged, and novel. And this is a process called, loosely, availability bias. Recency bias is actually its own thing. But in general, I'm using this to describe the features of things that we learn about and experience that come readily to mind. So to recap, most expert thinking is non-thinking. It's type 1 thinking, just like we did with the cardinal. What comes readily to mind? A cardinal. Are there other red birds out there? Probably. But what comes most readily to mind is the cardinal. Our memories are not perfect, and our experiences are not equally memorable. So what are we to do here? We know that the problem is occurring up here where we say, does a pattern recognize? Yes. And what we recognize are things that are memorable. So I'm going to point out two additional arrows that I added to this schema from last time. The first is the blue arrow, not the one I've circled there, but the blue arrow that goes from type 2 analytical up to intuitive. This is when you have so many choices that you give up and say, I'm just going to go with my gut. I can't think about this anymore. That might be how you chose your medical school. You had a big old spreadsheet of all the pros and cons, and finally you just said, I liked it at this one place better. That's intuitive thinking. We can do the same thing. We can say, I know it's a cardinal, 100%, I'm sure of it, but let me just stop and do some investigation and see if there might be some other red birds. And that's what I'm going to give you 3 strategies now, briefly, 3 strategies to pull yourself out of intuitive thinking, which is the expert's primary way of thinking, and double check. Just double check. The rule of 3 couldn't be more simple. This is the idea that you should always consider 3 diagnoses to avoid premature closure. That means we don't take the first thing that comes to mind that matches all the data. We say, let me consider 3 things, and not only should I consider them, but let me seek disconfirming evidence to rule them out. This goes against our human nature tendencies. When I get out of my house in the morning, I see a car that is the make and model of my car or the color of my car, and it's in my driveway. So I say, hey, that's my car. I don't come out of my house and say, how can I prove this is not my car? But that's what I'm asking you to do with the diagnosis that you feel very sure about. How can I prove? Do I have any evidence to suggest I'm wrong? Just consider it, even when it seems obvious and expected, like my car in my driveway. This can be applied to therapy as well. If you're giving a therapy, if you're giving a vasopressor, for example, and then you're giving a second dose, on that third dose, you may want to say to yourself, hey, is this the appropriate treatment? And perhaps more importantly, do I fully understand the cause of what I am treating? So the rule of 3 will help you to stop making your snap judgments and give consideration to a couple other things. Prospective hindsight is a strategy adapted from the military. You know, after something's gone wrong, everyone sits around in the root cause analysis and things seem so obvious. You point to the red flags. How could you have missed that? This was so seemingly clear. But in real life, it's not clear as it's happening. Prospective hindsight asks us to stop in the middle of an event and say to ourselves, when I find out later that I'm wrong right now, what will people say I missed? What will be those red obvious flags? And look around. And finally, 10 seconds for 10 minutes. Marcus Rahl and his colleagues came up with this concept. They basically say that we act too quickly in emergencies and that more patients are harmed from our rash actions than from a delay in treatment. This applies to emergencies. So he says, in an emergency, the leader should summarize the data, but withhold a diagnosis and solicit from the team, what do you think this could be and what should we do about it? And then assign roles and make a coherent plan to carry out over the next 10 minutes. So take 10 seconds or 15 seconds to plan for the next couple of minutes instead of acting rashly. Most mistakes are thinking mistakes. When diagnostic errors occur and patient harm occurs, someone has made a thinking mistake. It's not because they've not heard of the right diagnosis. It's not because the treatment is so exotic they didn't know to do it. It's because they made the wrong decision on that type 1 intuitive judgment where they recognized a pattern and they turned out to be wrong. In this little brain image, you can see that there's a lot of things that can influence us being wrong, but specifically we spoke about memory shifting and about availability bias. There are more. On the other side, we talked about rule of 3, prospective hindsight, and 10 for 10, and there are more, and I've talked about them on my blog. I want these strategies to become your habits. They have to be your habit, even when you know absolutely that you are right. You've got to be doing it when you're right. Why? Because, like Catherine Schultz said in her book and in her TED Talk, being wrong feels the same as being right. So if you're doing this when you're certain that you're right, and you're doing it every time that you are absolutely right, you'll also be doing it when you find out later that you are wrong. We are what we repeatedly do, Aristotle says. So in medicine, excellence is not an act, but a habit. Thank you.
Thank you, Dr. Stiegler. We're going to get my slides up here for a moment. My name is Lauren Riskin. I'm an anesthesiologist here at Stanford. And I like patient safety. Stanford recently finished its first patient safety fellowship within the Department of Anesthesia. So I want to talk to you about how physicians think about patient safety and what it really looks like in a hospital setting. So Meredith did a nice job talking about, from a patient perspective, what we can be doing to keep ourselves and our loved ones safe. And Dr. Stiegler just gave a nice cognitive framework to how some errors are made. For us on the medical side, the question is rarely how to keep bad physicians from harming patients, but really how to keep good physicians from harming patients. Care providers go into medicine often with very high aspirations of helping people. And it's very, very rare that someone ever maliciously intends harm to a patient, yet it still happens at an alarming rate. So it's really not a question of intent. And recognizing that over the years has really led us to change our medical culture so that instead of seeking out blame or looking for bad intent, we try to design and seek out systems that allow good physicians, good nurses, good therapists to keep our patients safe. as Meredith mentioned, medical errors are enormous, and the Institute of Medicine's 1999 report really brought to light just how extensive, how many tens of thousands, if not hundreds of thousands of errors there are a year. Hugely expensive, accounting for a huge number of inpatient and outpatient harm and death. So what is patient safety? Patient safety is freedom from accidental injury while receiving health care. It's the idea that we can create systems which will let you flow through without these accidents, which can come from a number of causes, will happen to you or someone that you care about. So we make mistakes. We make mistakes in our daily lives. We make mistakes in healthcare. And many of them are remarkably similar. So it's a rare day when I can't think of at least one mistake that I've made. And often these are little, and most of the time luckily don't result in patient harm, but little things like when's the last time you misplaced your keys, or grabbed the wrong pair of shoes for the gym, or forgot to water the plants, went into a room and realized you had no idea why you had originally gone in there. And I'm sure that I've probably misspelled something in this presentation, though not the word misspell because I looked it up. So cognition's important, but we make errors, and our healthcare providers, we make errors too. Sometimes it's sloppy handwriting, sometimes it's grabbing the wrong syringe in a hurry, but mistakes definitely happen. When they happen, it's important to look back, try to ascertain original causes and correct them, because it's repetitive mistakes that are really what's getting us. So I'd like to tell the story of Not This Baby Girl, and then walk you through a bit of what the medical system thinks and sees when an error occurs. So in this case, we're just going to talk briefly about a 1-year-old baby girl born at term, healthy parents, who was admitted at a week of age for a bacterial infection and needed some IV antibiotics. Her nurse, Linda, has been doing this for 40 years, very talented nurse. At the end of a long shift, it's been sort of a long week, and it's very busy. So while this baby girl is doing nicely, one of Linda's 4 other patients is probably going to have to go to the ICU, getting sicker and sicker. Linda is stretched pretty thin and doesn't really have all the time that she wants. So she asks Ted to help out. Ted's only been at this hospital for a couple weeks. He's pretty new. He worked at another hospital for about 6 months before. He's new to nursing, but he's enthusiastic. He went through all of his orientation. In fact, he still has a couple little things he's still orienting with because this is a new environment for him. But he says, hey, Linda, your other patient's not doing so hot. Tell me what I can do here so that you can go and focus on the patient who really needs your attention right now. And Linda says, sure. The patient's just finishing up their IV antibiotics. All you have to do is, take off the bag, close off the IV, and I'd really appreciate it. So when we close off IVs in medicine, we often want them to not clot. So we often put in a little bit of a blood thinner to make it so that the IV stays patent and no blood gets in and clots it off, because you don't really want to have to re-stick a poor little baby over and over again every time you want to give a drug. So we use a blood thinner medication called heparin, and that's kept in the Pyxis. And the Pyxis is a beast of a machine. It's a commonly used medication dispensing machine. I've, in my training, never been to a hospital that didn't have some brand or variety of these large machines with trays of medications, many different drugs available. So Ted says, okay, I'm going to help you out. I'm going to hep lock the IV. I'm going to get some heparin and I'm going to lock it off. And he goes to the Pyxis and he grabs, the vial and he draws it up and he puts it through the IV to keep it patent. Well, heparin comes in a couple different doses. And it turns out that in this case, for whatever reason, the wrong medication is given. and the baby ends up with a very, very high level of this blood thinning medication, and the baby actually starts to bleed. And it takes a lot of work when you start to have that amount of thin blood to stay alive. You can spontaneously bleed in a lot of places. So they recognize this when the baby starts to have a little bit of oozing. And I'm now realizing that my story is very morbid. But what went wrong here? So who is responsible for this baby getting the wrong drug? Not necessarily the wrong drug, but the wrong concentration. How are we going to fix this? Should we just, Ted, you should just never work here anymore. Like, you almost severely injured one of your first patients. Like, you should just not even be in nursing anymore. Like, just call it a day, go do something a little bit less risky. How could you even do that? How much blame can you put on Linda, who said, hey, sure, new guy, take care of my patient? Or Ted, who gave the wrong dose? Or the supervisors that maybe Ted was still supposed to be doing some orientation with? Can you blame the pharmacy? In this medication machine, somehow the wrong medication is getting delivered. Maybe a wrong drug was in a wrong spot or next to a similar drug. Can you blame the parents for not being there? Shouldn't you have a patient advocate with you at all times? Sometimes people even try to blame a patient. And in this case, it's hard because the patient is a 1-week-old baby. But sometimes people say, well, shouldn't, if you're not delirious or don't have dementia and you're old enough to participate, shouldn't you participate enough in your healthcare that error can't happen to you? So these are the vials of heparin. There is a 1,000-fold difference in their concentration. And this is unfortunately not as much of a fictional story as it should be, because in the 2000s, about 20 kids had this mistake happen to them. And it was really brought to light, the actor Dennis Quaid. It happened to both of his twins on the same night, as well as one other kid in the hospital where they were staying. And I believe that they all lived, but there have been a couple cases of this medication swap where this is 10,000 units per ml, and the other one, the correct one on your right, is only 10. So the way we look at this in medicine, so there are many different ways to look at how we deal with errors. The first, one of the easiest, is just ask why. Why did this happen? Why was the patient overdosed? Because Ted gave the wrong concentration. Well, why did he give the wrong concentration? He didn't notice. There was no scanning system, or when he drew it up, he didn't notice that the vial was not the vial that he thought it was. Why didn't he notice? Because they look very similar. Because they were stored right next to each other. Because maybe he was tired, maybe he was new at this, maybe he just honestly didn't know what the right concentration was. Why do the vials look alike? We'll get back to that. Why didn't Ted have the experience to notice? And if it was because he wasn't supervised, why wasn't he supervised? So accidents in healthcare are almost never from a single linear cause. And I don't know if there's anybody watching for whom this is unfamiliar, but in medicine we talk a lot about the Swiss cheese model. It's the idea that behind most errors, there are a lot of other errors, a lot of latent errors that didn't really cause a problem, that haven't been noticed. But when you start to line up the holes, when you line up those latent errors, some big, really active things can get through. And that's where you really start to get patient harm. So for every actual patient harm event, there are dozens of near misses, of accidents that were prevented and we may not have noticed. And so a lot of patient safety work goes into identifying not that one active thing of, does Ted need better glasses, but figuring out all those other holes in the system. One of the ways to do this is with a root cause analysis, which is when a team gets together from various different healthcare backgrounds in the hospital and talks about why an error happened and what were the contributing factors. So a physician named Vincent in the late 90s came out with a really nice framework that's still in use today. Different contributing factors and ways to kind of outline how things can go wrong. So patient characteristics. In this case, our patient couldn't speak up for herself, couldn't ask what a medication was or why it was being given. In this case, the patient characteristics of Linda's other patients, the really sick ones, just being a sick patient or being on multiple medications or having drugs that can cross-react, patient characteristics can cause a gap and lead to errors. Task factors, so very complex tasks. Actually, we'll line these up in what we call a fishbone diagram, but task factors, this actual task that involves look-alike vials, medication where there is no standard concentration, where there are no override alerts on the Pyxis when you go to take out the higher concentration, and no barcode scanning to guarantee what concentration you're giving and that it was the one ordered. Factors involving the individual staff, things like fatigue, lack of training, lack of familiarity, new personnel, the institutional context. So while we generally believe it's very appropriate to HEP-LOC IVs, we can always step back and ask the bigger question of, are we giving so many patients this medication that has potentially dangerous side effects? You know, is that really a good thing, and should that really be our overall algorithm? You know, do we need to be so aggressive with our diabetes management that almost everyone ends up on insulin after operations? You know, is there an institutional context here that's letting us get closer to creating errors? The work environment, heavy workload, is our nursing ratio of staff to patient, is that the most appropriate given our patients? Are we chronically short-staffed? Organizational and management factors. You know, do we have a casual attitude towards heparin because we use it every day? You know, have we created an environment where it's so second nature for us to give this drug that we've forgotten to, you know, respect how much damage it can really do? Do we need to be stocking a high-dose medication in our pediatric and neonatal units? Maybe there's just absolutely no role for a 10,000 unit vial in those units, or maybe in pediatric hospitals it should only come from pharmacy, because that's a very adult dose to have lying around. Team factors, was there poor communication? Could Linda have said something better to Ted, like, make sure to use the right concentration, or when you HEP-LOC the IV, use 10 units of heparin? Could we have a more formal handoff, less reliance on verbal communication? So when we sit down to figure out what went wrong, we'll often sort of really try to go through, really write out, here's what's going on, here are all the things. And then from there you get change. Then you write, statements of what needs to be done differently, because not necessarily everything has played a role. But by brainstorming all those things that could go wrong and really critically thinking about it, it's often better to identify things before they happen. And so a good root cause analysis will also look at all the potential sources of error. And there are other modalities for thinking about error that are much more proactive. But ideally, our goal is to become very proactive in our patient safety. It's not just heparin. The lookalike drugs are a well-recognized issue in patient safety. So I just wanted to point that out. Baxter, actually, the manufacturer of the lookalike heparin vials, did eventually recall them. Heparin is now packaged pretty differently, and also has even some extra pull tabs around the top for higher concentration ones. It's much harder to make that mistake now. So we're doing forced functions, having to remove a tab that has the concentration on it, storing them in different places. There are all sorts of ways that we can use our existing technologies to really build systems where it's now much harder to give the wrong dose of the medication than it was before. So the basic tenets, everybody commits errors. We all make mistakes. We all have slips. We all have lapses. Errors definitely happen. Human error is generally the result of circumstances that are beyond the conscious control of those committing the errors. Systems or processes that depend on perfect human performance are inherently flawed. Concentrate is not a plan. No healthcare provider comes to work to harm a patient. So we're trying, and it is a wonderful science to learn and explore as it's moved more from, it's become more of a science, more of quality improvement science and patient safety science, and has really grown a nice structure and is continuing to grow at a very rapid pace. So it's a wonderful opportunity to study, a wonderful opportunity to help people, and if any of you guys do want to get involved, I had a slide with my email address, which is lriskin, R-I-S-K-I-N, @stanford.edu.
And now we're going to take questions from the audience. If anyone has any questions for us. Yes.
So you had set up a model that suggested to sort of put cognitive checks in place. Mm-hmm. And then you had talked about these 5 whys. And I saw where I should probably use the cognitive process. But I was curious if you could talk a bit more about what triggers the 5 whys. Like you had mentioned, I probably make a mistake every day. But is every time, a cause for then generating this evaluation cycle? Or?
So typically the 5 whys is used, well, it can be used anything. So it can be used in your daily life if you're trying to figure out why it's the 3rd time this week you've burned the toast or forgotten your keys. But typically it's also used in situations of healthcare error to deal with some of the more complex questions. The patient was given a medication to which they were allergic. And it's easier, because sometimes there is sort of one why. I was tired, or I was distracted, or things like that in daily life, although typically the 5 whys are a tool that we use more for more complex error situations where we're trying to figure out between multiple players and multiple people the complex solutions that come out of working in such a complex environment.
If I could add to that, I think what the purpose of the 5 whys and root cause analysis is often to find and identify the ideal forcing function. So when we talk about having to do a special extra cap that requires a specific kind of removal that's different from another drug vial that forces a person to stop and think, to me that's analogous to some of the strategies I presented that force you to come from intuitive down to analytical. Anything that requires you to stop and think, that is literally a hard stop, will take you out of this automaticity, because we make our diagnoses just the same way as we go into a room and forget why we're there. We spend 90% of our waking hours on autopilot. So I think asking those whys until you get beyond Ted's careless or Ted's tired to what can we change in the system to make Ted have to have given it his due attention, I think that's the real benefit of the 5 whys.
So we're 15 years out from the IOM report. We haven't moved the needle at all on killing patients. If you are going to make the med school of the future with the caveat to never harm a patient, how would you go about training med students and other healthcare providers so that they don't create the same problems that we have currently?
Who are you asking?
Well, it's a terrific question, because obviously it's true we're still making a lot more medical errors than we'd like, and And while we've managed to stop certain ways of, we haven't managed to completely stop certain ways of error, but while we've made very broad system changes to reduce error, like surgical timeouts confirming that we're all working on the correct side, or required allergy checks or 2 patient identifiers, it's true that what we're also finding is new and interesting ways in which to create patient harm. I do think that awareness is a huge part of solving the problem. More education about how we think and how we make decisions and how we create safe systems, getting more people involved in what we call the culture of safety, where it's okay to talk about error so that we can learn from other people's errors and not only have to make them ourselves and learn internally. But I do think that there are a lot of educational resources that aren't necessarily being as highly utilized. I know that we're pushing hard to get our residents to go through the Institute for Healthcare Improvement's online courses at ihi.org, which are a wonderful learning resource and give a really wonderful overview of patient safety and quality projects. I think a lot of it comes down to education. What do you think?
I think a lot of it does come down to education, and I think one of the areas in which we have moved the needle quite a bit, but there's still a tremendous amount of work to be done, is sort of on leveling the team, if you will. So there is a tremendous power in relationship hierarchy and authority gradients, which is why the 10 for 10 rule says that the leader should not say what they think the diagnosis is, but instead summarize the data. Because we know from groupthink studies that if I'm the leader and everybody thinks that I've got it under control and I tell you what the diagnosis is, even if you've noticed data that seems to be in discrepancy with my idea, you probably won't speak up. And so we talk about patient safety, the culture of safety, empowering everybody to speak up, but the reality is we need to change the way that leaders lead, or that's just simply not going to happen. You can't focus on sort of the lowest person on the totem pole and say, you need to speak up. We need to focus on the top of that totem pole to change our behaviors, to solicit and encourage the input. And then, although this is slightly separate, we need to be sure that our hospital institutions really support that. So if we have folks who are known for their bad behavior, who give people on their team a bad time, and we condone that even if tacitly because that person is not reprimanded for inappropriate behavior, then it doesn't matter how much we sing about teamwork. It's going to still squelch the ability of anybody else to raise their concerns. And we can do team steps training and things like that until we're blue in the face. It will not matter at all unless the leadership really takes a change. So that's not really changing education, but it's changing the environment in which we educate.
And I would say, just going back and reiterating what I mentioned before, just really embracing the culture of safety. Like I think all 3 of us said, when we wake up to come to work each morning, nobody wakes up with the intent to do a patient harm. You want to go to work and do your job and be efficient, because you have all these different tasks. But extrapolate that thought. I want to get my work done. I want to be efficient. I want to do it in a safe manner. So what I'm doing, am I doing that safely? And we also have a question from the audience that I would like to pose. The idea of a differential diagnosis is standard teaching in medical education, but you're saying that experts don't really do that. Can you elaborate a little bit more? This question is for Marjorie.
Sure. So I think that's true. We do start off teaching everyone in medical student land to generate a differential diagnosis. That is how people learn to sort of amass the patterns. What is different between this diagnosis and that diagnosis? What are the signs and symptoms that we should see and don't see? But over time, again, we really develop those GIST patterns, and then the expert really does not rely on that kind of thinking anymore. So we talk about the differential diagnosis in medicine, but the reality is that when you go to your physician in the clinic and you have something that doesn't make them scratch their head, if something pops to mind that they think is plausible and really fits the bill, you went hiking and now you have a linear rash, you've got poison ivy. And there's no thinking really that's gone on to draw that conclusion. So experts are both efficient and accurate using that methodology. I should really emphasize that. This is not a bad thing. It's really a good thing. It helps us see all of our patients, 1 million patients a day. It helps us be efficient in our clinics and respond to emergencies quickly. And almost all the time, it's good because experts are accurate and fast based on this acquisition of patterns. It's just that if we take a look at the subset of patients who have been harmed from delayed diagnosis or missed diagnosis, that 80% of those patients had a type 1 thinking error involved, if that makes sense. So if we look at decisions overall, we're doing a great job. If we look at decisions where harm's been done, this is a target for intervention.
We have a question in the back.
Yes. This is sort of speaking from personal experience, where in the past, when I've been involved with an error, I find myself so horrified, so self-defeated from it, that the subsequent encounters I have, I almost feel paralyzed from not wanting to make another error. And my thinking slows down, I panic, I stress, I worry. So how can the average practicing clinician be mindful of these important things, but also not be paralyzed at the same time?
Are you asking me? I think that's a really important question because it speaks to a concept that we're not really talking about today, but that is gaining some traction in medicine called second victim. So if you have done something that's harmed a patient, certainly the patient is a victim and their families are a victim, but you yourself are also a victim of sort of the adverse emotional toll that that takes. And depending upon the severity of the event, if there was a death or a serious harm or even if you were sued, that can trigger symptoms very similar to major depression and even to PTSD. And so when you see another patient who has something that's even close, you start to panic. This is really important, I think, because if the errors are small, then our question is a little bit different. But if the errors have a serious magnitude, I think it's really important that our institutions understand that, support clinicians, and automatically remove us from patient care until such time as we're sort of back in the right mental state. And I had a recent phone conversation with Captain Sully of the Miracle on the Hudson, as everyone's heard of him, right? And while we were talking about safety and crisis resource management and stuff like that, it occurred to me as he was telling me that they had this big orchestrated debriefing for them and their families for what to expect, and that they would have PTSD-like symptoms, trouble sleeping, trouble concentrating for months. And I thought, well, nobody is going and plucking Sully out of the Hudson and saying, hey, can you get back to JFK? There's another plane we've got to take off. And we do that in medicine to each other all the time. So again, it's got to come from the top. People have to understand we're people. We make mistakes, we have feelings, and those things impact how we treat subsequent patients.
Yes. You stole my answer.
Oh.
Second
Sorry.
victim. No, beautifully said. But
Hi, I'm not a medical student, obviously.
You might be.
Not this year, maybe next year. However, I'm delighted that you all are here speaking about this because you've made some excellent points that I wish I hear more in the outside world, away from Stanford. Could you speak something related about the difference in the generational attitudes of physicians? Because I see that you all are really empathic and wanting to get to the truth. My experience has been that with some, and I'm generalizing, that some generational differences exist in the younger students, the younger practitioners, and the younger doctors, as opposed to a very respected and honored older doctor, physician who might have a different attitude about admitting an error or even being concerned that maybe they don't know what the answer is. And the other concern I have is the quality of medical records that get passed from one doctor to another, where it is so difficult to make changes once the error is known. However, patients have difficulty accessing to see whether information about them is really accurate. Thank you.
So to start with the first part in terms of generational changes, as a fairly young physician, it's always a little hard for me to speak to that. But yes, but here I go. So I do believe that there is a gradual change. And while I can't say it's from my own personal experience, at least when I look at the growth of patient safety and quality improvement as fields, and look at the number of organizations dedicated to their pursuit and to patient advocacy, the numbers are there and they're really growing. So quality improvement is something that wasn't ever discussed before a MGH professor got kicked out of the hospital in 1910 for suggesting that every physician track their patients on an index card and decide whether the surgery had been a good thing for them or a bad thing for them. And he basically lost his job over it. And then we get to later points where the Anesthesia Patients Safety Foundation was founded in the late 80s. And the National Patient Safety Foundation not that long thereafter. And now we have some wonderful foundations and organizations that are really getting the word out. The Institute for Healthcare Improvement, the National Patient Safety Foundation, the Anesthesia Quality Institute, things that have really grown in the last couple decades. It's become a big part of medical education as well. Our accreditation body for graduate medical education now has a core competency requiring that residents do a quality improvement project at some point during their residency, and a lot of that falls under patient safety. So certainly, it's definitely growing. It's definitely becoming more of a science. It's definitely becoming more discussed. There are more people affiliated with it and in areas of it than there ever were before. And so I think that the culture is gradually changing. As to how we address some of the laggarts or some of our more recalcitrant surgeons, perhaps, like that's always a struggle and always an individual kind of thing. But I do think that institutions really are trying to create cultures of safety, create anonymous safety reporting. So if somebody feels someone else is unsafe, they have a non-threatening way to hand it over to a higher authority. That sounded really 12-steppy. To pass it along to someone else who can deal with directly with anybody who is a little bit hostile or inapproachable or not creating a culture in which safety can be discussed. Because we do want to get to that point, as Dr. Stiegler mentioned, any nurse should be able to ask any doctor, any respiratory therapist, did you wash your hands or do you know about that patient's allergy? We want to be able to have those open dialogues. Does that answer your question? It is encouraging.
This has been a wonderful discussion tonight. I hope that everyone was able to take a nugget of information away and embrace the culture of safety a little bit more. We are out of time for questions this evening, but thank you for participating in medical education in the new millennium. Have a good evening.
If you like what you see in this class, be sure to check out our online course, Engage and Empower Me, a new online class from the Stanford University School of Medicine. We are featuring presentations from patients and experts on participatory medicine. Through this course, we hope to empower you to take part in creating a more inclusive and collaborative healthcare system. The course can be found at class.stanford.edu. As a reminder, this program is made possible by support from the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. If you haven't yet done so, please take a moment to like our Facebook page at www.facebook.com/Stanford Med X so you can continue the conversation online and stay informed of program updates. From all of us here at Stanford Medicine X, we want to thank you for joining us tonight and to remind you to join us again next Thursday, November 27th at 6 p.m. Pacific Standard Time for another edition of Stanford Medicine X Live, featuring a new class on medical education from the Stanford University School of Medicine called Medical Education in the New Millennium. Next week, we are featuring President of Innovations in Learning at Clinispace, Dr. Parvati Dev. For all of you out there taking time to tune in with us tonight, thank you for joining us and being part of the conversation. A special thanks to our guest panelists this evening. From all of us at Stanford Medicine X, we'll see you next time.